So hello, everyone. Thank you for joining us. My name is Kim Edwards, and I am the Senior Manager of Health Communications at SysGroup, otherwise known as the Center for Information and Study on Clinical Research Participation. For anyone that might not know, SysGroup is a nonprofit organization dedicated to increasing awareness and transparency around clinical research. Today's webinar is part one in a two-part series on postpartum depression and clinical trials. Today we'll be discussing primarily postpartum depression, or PPD, and during the second webinar we'll focus on clinical trials and PPD. So welcome, we're so thrilled that you're here. Thank you again for everyone joining us today. I just want to note later on, if we have time, we'll be selecting questions from the question and answer box at the bottom of your screen. You'll find it. So this is not the chat box, this is the Q&A box. So feel free to submit any questions that you might have throughout the webinar. Before we get started, just a disclaimer that this presentation is not intended for continued medical education credit for healthcare professionals. And this webinar was funded by Sage Therapeutics, and the speakers you will be hearing from today are receiving honoraria from Sage. Go to the next slide, please. Thanks. So the format for today, first we'll be hearing a testimonial from Alexis, a postpartum depression disease awareness ambassador. We're extremely fortunate to have Alexis with us here today. Next, we will have an overview of postpartum depression. And finally, we'll have a facilitated discussion with our panelists on topics including PPD, perspectives from different sides of healthcare, some strategies to support a loved one with PPD, and how COVID-19 has impacted PPD. So I'd love to just jump right in and hear from Alexis, if she would be so kind to share her story with us. Thank you. I'll turn it over to you, Alexis.
Thank you, Kim, and thank you, Sage, for having me today. Again, my name is Alexis, and I'm excited to share my story with you. There were times in my struggle with postpartum depression when I truly believed in my mind that I was not good enough. I wasn't a good wife or mom. I was nothing. And my entire family would be better off if I ceased to exist. That voice inside my head filled my mind with so many lies. Thank goodness there was this tiny whisper saying, "Keep pushing. You are not alone. It will get better." I want to be that whisper for other women. The voice that says, "You're not alone. You're not a lost cause. You are not hopeless." I want women to know it's okay not to be okay after you have a child. These feelings you're experiencing, you are not alone in feeling them. And they don't make you a bad mom. Today, I'm privileged to share my story with you. My desire is for you to find yourself in parts of my journey and to find hope in knowing that even the worst storms come to an end. Before I begin, let me thank Sage Therapeutics for sponsoring me to be here. Please remember that this story is based on my own experience. Yours may be different. You should always talk to your doctor about any question regarding PPD. Fast forward through my life to my early 20s. I had been married to the most amazing man in the world for 2 years. And we had been trying to conceive for about a year. Finally, we found out we were expecting. My family, my friends, and my husband and I were overjoyed with the news. When we found out it was a girl, I was even more excited. Instead of reading books about pregnancy, I was worried about baby clothes, shopping, and decorating for her room. I even hired a personal decorator. I pulled out all the stops when it came to my baby's physical things. I was not thinking about the crying, the pooping in the bathtub, getting up every 2 hours to breastfeed, or spit up running down my back. I thought everything was going to be cupcakes and rainbows with a cute little cherry on top. I knew of the baby blues, and my mom had mentioned PPD in passing, but I didn't know much about it at all. I ended up having an amazing pregnancy, and when it came time to deliver, I was extremely excited and anxious to see our precious baby girl. Every woman hopes for a smooth pregnancy. I did not expect to have an emergency C-section and to be told that my baby had swallowed meconium and may have to be airlifted to a bigger hospital for care. I was terrified. I begged the nurse to tell me I was not going to lose my baby. And my husband's teardrops fell on my stomach as they wheeled me to another room for surgery. Thankfully, my precious baby girl was perfectly fine and healthy. I was sent to another room to recuperate. And many of my family members were able to see our little girl before I did. When they finally brought her into the room and placed her in my arms, I did not feel that instant connection everyone had talked about. I looked at her like I was holding an alien from another planet. We stayed in the hospital for 4 days, and I continued to feel nothing. I didn't want any visitors, and I begged the nurses to take her so I could sleep. I wondered, why don't I feel the things that I thought I should? But I figured I was exhausted. Things should get better when I get home. My behavior only got more bizarre when I came home. I still did not want to care for my baby. And when she was sleeping, I did not want her to wake up because I did not want to move. I did not want to breathe. And I did not want anyone to know. I will never forget the many comments my family made about me sleeping so much. One of them even said, "You just have to choose to wake up and be there for your baby." I recall my dad asking why I slept so much. And I told him, "I feel like I am on a ship, and the ship is my depression." The captain is my anxiety, and the safety raft is my bed. The only time I found peace during this time was when I was asleep. The extreme guilt of not having a bond or being able to bond with my baby haunted me for months to come. I wanted that bond. I just couldn't feel it. It was like there was this dark shadow standing between me and my daughter. I began to have suicidal thoughts very early on. And I felt guilty about that as well, because everyone tells you this is supposed to be the happiest time of your life. But it wasn't. All the light disappeared around me, and I was left with darkness. I sought out help very early on and went to see my OB, who told me it was probably just the baby blues. When it lasted longer than a few weeks, I went to one of our local psychiatrists and counselors. I was diagnosed with postpartum depression. I ended up switching psychiatrists and medications many times, and nothing seemed to be working. There was a reoccurring image I had throughout my postpartum. I imagined myself at the bottom of a muddy pit. I tried desperately to climb my way out of that pit. But just when I began to make progress, the damp earth would give way and I would slip back down to the bottom to start all over again. I knew something was very wrong, but I wasn't educated enough about PPD to know what to do. And it was hard to seek out help. My state doesn't have many doctors who specialize in postpartum depression. Finally, after a few months, I voluntarily checked myself into a psychiatric hospital where I remained for a month. At one point, I was sitting and waiting to see the doctor when I overheard the social worker telling the counselor I was faking it. I slid even further into the abyss. If they did not believe me, then who would? I did not get any better once I was released. Anger consumed me. I was mad at other people, other moms, for being happy when I wasn't. How is the world still moving for you when I feel like it's standing still? I began eating to fill this void inside of me. I tried everything I could to numb the pain. I harmed my body and struggled with thoughts of not wanting to be alive anymore. I felt empty. But part of me still held on to a glimmer of hope. And I think what really kept me going was the major support system I had. My mom, my dad, and my husband, Derek. If life was a fairy tale, then my husband would be the knight in shining armor, riding in on a white horse. He never left my side and never gave up on me. Even during a time when I had given up on myself. He is the kindest, most genuine, and honest man I have ever met. Derek and my parents took care of my little girl when I could not. They also took care of me simultaneously, and for that I am eternally grateful. Because of them, I did not give up. I searched, I Googled, and I studied everything I could about PPD. I found a forum for women with PPD to talk to each other and made some major connections. This gave me even more hope, especially living in a small town where not many people knew or talked about PPD. Through it all, my counselor did not give up on me, and I think the relationship that we've created is one of a kind. I look up to her. Something she helped me realize was that I had become my own worst enemy with treatment. I wanted every treatment to be a quick fix, and I think this was why I changed medications so many times. When I found a new psychiatrist, in addition to my counselor, I was able to be honest about my history. And he worked with me on finding and sticking to a treatment plan that was best for managing my symptoms. After about a year of counseling and visiting the psychiatrist, I was finally able to begin the healing process. It would take time. but I began to see the light at the end of the tunnel that my counselor and my family told me I would eventually see. I began to truly laugh and smile again. Life became brighter, more colorful, and the darkness slowly began to drift away. But my healing continues every day. And during this journey with PPD, I've learned some important lessons. 1, never give up. This does not last forever, even when you've convinced yourself it might. 2, don't be embarrassed. Talk to someone. Reach out. Having support is extremely important. If you don't have a support within your family, find yourself a support group. 3, self-care is a must to help us. Love ourselves and be the best versions of ourselves. Give yourself 30 minutes to an hour every night. It doesn't have to cost you money. It could be as simple as a bubble bath or reading a book. No matter what it is, do something for you. A lot of moms lose themselves in taking care of their children, but self-care helped me become a better mom. 4, do your best not to feel guilty. I experienced so much guilt because I thought I couldn't be an adequate mother to my daughter. I couldn't even get out of bed. But my daughter is my best friend now. Our bond is stronger than ever, and she has no recollection of the past. I think that is one of the most important things I want moms going through postpartum depression to know. Because we put so much guilt on ourselves for not having that perfect relationship with our little ones. The last lesson I've learned is to tell your story when the time is right, because it can help you heal and also help others heal. And know they are not alone in this. I do believe that life is made up of a series of journeys, some good and some bad. Today, I'm thankful for all of them because they led me to where I am now. I did not give up. I made it out of the darkness. And through the pain, I found a strength and courage that was always there, but needed prompting to come out. I hope that someday you will look back and feel that way as well. Thank you.
Thank you so much for sharing your story, Alexis. I think I can speak on behalf of everyone here today that hearing your story is incredibly impactful and I'm sure extremely relatable for many here, and hopefully provide some comfort to folks so they know they're not alone in their feelings. So thank you truly for being here today. We really appreciate it. I think it's also going to be great to hear our panelists a little later on speak a bit more about the topics you've raised, Alexis. So I think now would be a good time to introduce our panelists before we dive into our overview of PPD. So our first panelist is Heather Daub. Heather is a mother of 2 children and a survivor of perinatal anxiety, depression, and suicidal ideation during her 2nd pregnancy. Learning from her lived experience, Heather's advocacy has taken her from the halls of the Utah State Capitol to the United States Capitol with the purpose of improving awareness and increasing resources available to mothers facing maternal mental illness within the United States. She is a mom and ambassador with 2020 Mom, a national organization with a mission to close gaps in maternal mental health care. And our second panelist is Dr. Jason James. Dr. James is a board-certified obstetrician gynecologist who has been in private practice in the Miami area since 2003. Dr. James completed his undergraduate education at the University of Pennsylvania, attended medical school at the University of Miami, and completed his residency in obstetrics and gynecology at the Long Island Jewish Medical Center. Dr. James is skilled in laparoscopic and robotic gynecologic surgery, minimally invasive surgery, infertility, and high-risk obstetrics. He has special interest in postpartum depression and was named the 2010 ACOG Issue of the Year Research Award recipient for postpartum depression research. He enjoys spending his free time traveling around the world with his wife, Lisa, and 3 children. And our third and final panelist is Dr. Constance Gill. Dr. Gill is an associate professor in the Department of Psychiatry and Behavioral Sciences at MUSC. Dr. Gill completed her psychiatry residency training and subspecialty training in perinatal psychiatry at Yale University. She established and is currently the director of the Women's Reproductive Behavioral Health Program at MUSC. The mission of the program is to improve the mental health of pregnant and postpartum women through clinical care, education, teaching, and clinical research. Her research is focused on investigating the biological markers of postpartum depression. She is a mother of 2 beautiful daughters as well. Thank you to all 3 of our panelists for being with us today. We're so fortunate to have you. Thank you. So now I'm going to turn it over to Dr. Gill, who is going to give us an overview of PPD.
Great. Well, thank you so much for the introduction. And Alexis, thank you again for sharing your story. It's very impactful and I really much appreciated. And thanks to Sage for bringing this group together. I'm really excited to be talking with all of you. I'm going to give just a really brief overview of postpartum depression. Next slide. And first is just defining what postpartum depression is. According to the American Psychiatric Association, they define postpartum depression as a major depressive episode that occurs during the peripartum period. And they define that as at some point during pregnancy or within 4 weeks postpartum. Next slide. American College of Obstetricians and Gynecologists and the World Health Organization extend that period a little bit longer. It's the same definition, but just a longer time period. And so clinically, we basically say if someone's had an episode of depression during pregnancy or the postpartum year, we're going to call it postpartum depression. Next slide. So actually, Alexis brought up a really good point about differentiating postpartum depression from baby blues. They are 2 very different and distinct entities. So baby blues is really common. About 80% of women will experience that following childbirth, and it peaks within the first few days, and it resolves within 2 weeks without any treatment whatsoever. The most important thing about it is that the symptoms are not severe and they do not impact activities or functioning in any way. Versus postpartum depression, which we say, estimates really vary in terms of the prevalence, but we say basically roughly 1 in 8 women will experience postpartum depression. We've talked about the differences in timing of onset, but without treatment of this disease, this will last for months up to a year. These symptoms can be really severe and actually really impact someone's functioning in any domain. So it can be socially, it can be in their work, in their ability to take care of themselves, and ability to take care of their baby or their children or home, and affects mother-infant bonding. So really a cluster of symptoms that are severe enough to really impact someone's ability to function. Next slide. So postpartum depression is actually one of the most common complications of pregnancy and childbirth. It's actually more common than a lot of the other diseases that are equally as important, but that we spend a lot of time thinking about and monitoring in pregnancy and the postpartum year. And you can see kind of the prevalence rates here. Next slide. So one of the things that's important to think about is who's actually at risk for postpartum depression. Well, there are a number of risk factors that have been identified, although people can have postpartum depression without any of these risk factors. But one of the strongest risk factors is someone having a history of depression. That's a very strong risk factor for postpartum depression, as well as any major stressful life events. That can include things like past complications in a pregnancy or current complications, having a history of sexual abuse or being in a situation of domestic violence, low socioeconomic status, and poor social supports. So having very few social supports, having difficulties in your relationship with your partner, those are risk factors for postpartum depression. Next slide. This just actually highlights and kind of drives home the point that if you're going to look for any risk factors, probably one of the most important one is looking for a history of depression. So the risk for postpartum depression in those that have a history of depression is about 20 times higher than people that don't have a history of depression. Next slide. So as Alexis pointed out, there's a lot of variability in how people present with symptoms of postpartum depression. And I think that that's oftentimes what makes it very hard for people to diagnose. And so when we're looking for this, what we're really looking for is a disruption in somebody's mood that's very different than how it has been in the past. And that disturbance is happening most of the day, nearly every day for at least 2 weeks. And that can look like sadness, emptiness, helplessness, worrying constantly, or just feeling anxious and on edge, irritability, being very snappy, or even feeling rageful. Loss of interest in anything or just any activity that maybe once found pleasurable. We call that anhedonia, just not being able to get pleasure or any enjoyment out of anything. We often see that women thinking about just not just having doubts about themselves as a mom and their ability to parent, and having difficulty bonding with their child. Also experiencing suicidal ideation, just thoughts about wanting to die. We also see some impairment in cognition, so ability to concentrate and remembering details, but the one that I think stands out the most in the cognitive domain is trouble making decisions. So women have a lot of decisions to make during this time, and you can see this constant back and forth, not able to make a decision. They're very ambivalent. The somatic symptoms that go along with postpartum depression are sometimes difficult to differentiate just from what are some of the normal physiological symptoms that you would expect after having a baby. But the ones that stick out are often around sleep. So as Alexis mentioned, hypersomnia, so just sleeping a lot more than that you normally would sleep. So if you slept 7-8 hours before and you're sleeping now 12+ hours, that would be considered hypersomnia. Insomnia, that's pretty easy to pick out because oftentimes women are really sleep deprived. And so they'll tell you, look, I haven't slept in forever, but I lie down and I cannot sleep. I have these thoughts that come in my mind. I'm anxious, I can't sleep. And that's really the insomnia that we see with depression. Appetite changes, some of these other psychomotor and somatic symptoms can appear as well. Socially, we see women really withdrawing from friends and family and supports. And as I mentioned before, all of these symptoms are causing a significant amount of distress and impairing a woman's ability to function in important areas in her life. Next slide. So these data just highlight how often postpartum depression is undiagnosed and undertreated. So if we're not screening for this disease, approximately 50% of these cases will go undiagnosed. We know that with screening, actually, you will increase the number of people that you're identifying. One of the challenges is you can identify folks, but getting them to treatment is difficult, and there's some barriers that can get in the way, and we'll talk about those in a minute. But we know that roughly 25% or less of women will get to treatment after screening when they're given a referral to treatment, but they don't actually make it to their services. Next slide. So these are some of the common barriers that get in the way of women accessing services. So you can read some of these, but one of the things that often stands out to me is how often women are unaware of the impact that their depression or their anxiety or their mental health problem has on their health, but also on their newborn's health, their children's health. And oftentimes when women learn about how this does impact themselves and their child's development, they are much more interested in treatment. So they'll kind of prioritize their health because in the end, they're prioritizing their children's health. And that really helps women to overcome those major barriers such as time or lack of access to childcare, and the stigma that often goes along with postpartum depression. So next slide. So I will go ahead and stop there and we can open it up to the rest of the panel for discussion. Thanks so much for your time and attention.
Thank you, Dr. Gill. It was super helpful. I just want to mention that at the end of this recording, at the end of this webinar, the recording and all of the slides and materials will be available through SysScript to use as a resource. And I also wanted to remind everyone that we are taking questions in the question and answer box. So please feel free to add some in as we transition now to the facilitated conversation with our panelists. Of course, we may not be able to get to all the questions due to time constraints, but we will, of course, do our best. So now we're going to have a facilitated conversation with our panelists. Maybe our panelists just want to wave your hand and say hello as I say your name, just so you can pop up on everyone's screen. So first we have Heather Dodd.
Hello.
Thanks, Heather. Dr. James.
Hi, everybody.
Thank you. And Dr. Gill, who we just heard from. So first off, I'm just going to ask some questions to get the conversation started. Firstly, we are so fortunate, as I mentioned, to have with us today 3 panelists that sort of represent different aspects or areas of healthcare. From your unique perspectives, what can healthcare providers be doing to better identify and support those experiencing PPD? Maybe we can hear from Dr. James first, give Dr. Gill a break from speaking.
Sure, absolutely. Well, first off, I want to echo Dr. Gill's appreciation for Alexis's story. And I think that it really just exemplifies what many women will experience. And it's very brave of her to share her story with all of us. I mean, there's 150 people participating, and for all of us to hear what you went through is heart-wrenching. But like you said, the most important message out there is that you're not alone. And I think that to answer the question that was posed, what can healthcare providers be doing to improve the situation? And I think the most important thing that we could be doing is screening. Dr. Gill said in her presentation that if we screen more, we'll find more. And that's certainly been proven time and time again. And despite that, and despite the fact that postpartum depression has become part of the national conversation, I think that the frequency with which healthcare providers are screening for postpartum depression is still extraordinarily low. And it just points to the opportunity that exists to reach out to whether it's the OBGYNs at the postpartum visits, whether it's the hospitals taking the burden upon themselves and reaching out as we've employed at our hospital. We have volunteers calling every patient who delivers 3 weeks after delivery to inquire about their mental health, whether it's the NICU, because those moms are at significantly higher risk because of the stressors that they're going through. And actually, I think the pediatricians have a huge role as well, because pediatricians are seeing moms multiple times in the several months after delivery, compared to maybe once or twice for the OBGYN. I know in my specialty as an OBGYN, it's very easy to screen, and yet it's just not being done frequently. And I think one of the reasons is that physicians or other healthcare providers are just scared of the results and not really sure of what to do with those results. And there's so many resources out there. So I think that's the number one thing, is screen. The misconception that, oh, my patients don't really suffer with postpartum depression, I think I would know it just by talking to them, is definitely a misconception. If you do a validated screener, you will find patients.
Yeah, Heather, as a patient advocate, I'm really curious to hear your thoughts on this topic as well.
Yeah, I appreciate the question. As Alexis said in her story, that she didn't have many people in her community who were trained in treating perinatal and postpartum depression and other anxiety disorders. She didn't have any resources who were adequately prepared to help her. So one thing we work really hard on is making sure that providers are educated and they're receiving the proper training, and that's spanning from screening tools to medication and other treatments that aren't medication for mothers who choose not to go that route or for whom medication doesn't work for. So one of the biggest needs we see is that providers seek out the training that they need to adequately treat these mothers.
Yeah, Dr. Gill, from a psychiatrist point of view, what are you noting?
Well, I actually agree with both Dr. James and Heather that, we have to be screening. We need to get access to appropriate care. I also think that we need to be doing a lot more collaborative care with the OBGYNs and pediatricians so that they're actually supported in taking on this massive thing, which is screening for mental health and getting people to treatment, right? OBGYNs already are doing so much. Their list of problems for patients is so long, and now we're asking them to take on mental health. And so I think the more that we can support them in that, providing access to people that can do evaluations and get women into care quickly and appropriately, I think that's one of the next steps that we need to be working on.
Yeah, you perfectly led into my next question, which was what can, different types of healthcare providers be doing to work more collaboratively to, better support those that suffer from PPD. I'm curious, Dr. James, Heather, if you have any thoughts on sort of the collaboration across healthcare professionals, can build off what Dr. Gill was discussing. Yeah, Dr. James.
Yeah, I'll start with that. I think that probably one of the biggest fears, like I had mentioned, is that if I screen a patient and she's positive, now what? What do I do with that information? I think doctors are worried about a loss of follow-up. They don't know who to refer to. There's a lot of fear of liability. What if I identify a patient who's got suicidal ideation and then I don't get her immediately into help and something happens? Am I liable? And actually, I think the opposite is true. If you had an opportunity to help and you didn't screen, you're just as responsible. So, as an OBGYN who delivers babies, we're responsible for holistic care, mom, baby, and that includes mental wellness. So I think what Dr. Gill kind of touched upon is, I think doctors need to have like an established plan. So, don't get caught by surprise. If you have a patient who tests positive and she needs care, have a list of resources, counselors, therapists, support groups, Postpartum International, any of a number of groups, so that you know exactly what to do and you're not in that panic mode to worry about what to do now that you finally found a positive screening.
Yeah, makes a lot of sense. Heather, did you have anything to add as someone that's sort of, more intimately involved in the process?
I want to echo something that Dr. James said earlier about having the aftercare check for postpartum depression and anxiety, all those various disorders. We see the OBGYN or provider at 6 weeks, and then you're off, you're done. But we take our babies at 6 weeks, 1 month, 2 months, 6 months, 18 months, 12 months. We're always in constant contact with our either pediatrician or family practice. So why don't we have those physicians or providers checking us as well while we're in the office and we're talking about this child? Mother's mental health and well-being matters as well. That's a perfect place to do screenings up until the 12-year mark, because we know that from 4 weeks to a year, this is the open time when postpartum hits. So that's the perfect situation, is to just screen when we're checking out our babies.
Yeah, I think that makes a lot of sense. From all of your perspectives, how have you sort of seen the landscape or understanding and treatment of PPD change over time? I'm imagining it's changed a lot over the past several years. Yeah, Dr. Gill, I see you came off mute.
Yeah, I'll go ahead and start with that. So, I've been working in this space for over 10 years. And when I first started, we talk about stigma now, the stigma then was just so palpable. This was so shameful. People did not want to acknowledge this. And I think what we're working towards and what I've seen is the normalizing of maternal mental health. So just like we monitor glucose and blood pressure all through pregnancy, now we need to be monitoring mental health and well-being. And that just becomes part of routine normal care. And the more that people kind of understand this disease and understand that it's common, there's treatment available, it's nothing to feel shameful about, that I think we're moving in the right direction. But it has been, I've been doing this for a decade and it's taken a while to get here. But it's definitely encouraging.
Yeah, definitely. We have a question for Heather. if you could speak a little bit more specifically about stigma and access to care from your point of view.
Sure. Stigma and access to care. Yes. Okay. So with stigma, at least, well, for many women that I've talked to across the United States, we don't know about postpartum and perinatal mental disorders in the first place. And so when it happens to us, we're kind of already experiencing mom guilt, and we don't want to own up to it because maybe we're the only ones. We haven't heard our friends talk about it. We haven't heard our providers mention anything about it a lot of times. So a big thing we can do to reduce the stigma is to talk, to share your story. As Alexa said, when the time is right, not everyone is in a place where they can talk about it right away, but one of the best things we can do for the community is to say, hey, this is my experience. I'm fine. Here's how I recovered, or I'm going through this right now, and I'm here to walk with you if you're going through it too. So that's a big part in reducing stigma. Another thing about barriers to care, I can speak as a resident of Utah. We have moms all over rural Utah who don't have access to perinatal postpartum trained providers. So for some, it's as little as I can't leave my town and drive 100 miles to speak to an OBGYN or a psychiatrist who can treat me. And we've been able to work through that with telehealth, fortunately. And then in others, it's a matter of race. We know through health equity that some women of color, don't always have the same access to care, or aren't treated the same in the doctor's office. So that's another big thing, is that a lot of women fall through the cracks from health equity standpoint, from physical location standpoint, or lack of training. A big barrier is the lack of training for our providers. So, and I just wanted to say really quick that 2020 Mom and Postpartum Support International put on trainings regularly for providers so that they can have the tools from pharmacology screenings, non-invasive treatments that don't involve medication. These are always available. We just want to bring this to the community so every mother has access to the appropriate care.
Thank you, Heather. Yeah, I think reducing the stigma is definitely something that we've seen in the mental health space, reducing the stigma, but definitely something that we can still continue to be working on, of course. Dr. Gill or Dr. James, do you have any sort of advice or thoughts on how we can be better reducing the stigma around PPD?
I think that just normalizing the situation, I think making it as part of one of our routine questions, how's your mental wellness? For me, it's a very open-ended question. You see a patient during her pregnancy about 20 times. And for me to just ask how she's doing, how she's coping, is she feeling down or depressed? Is she feeling anxious, guilty? All the kind of non-judgmental questions. But if I ask it all the time and get lots of no's, it kind of normalizes the situation. So that way, I don't think that the patients feel very stigmatized if all of a sudden I were to ask them in the postpartum and all of a sudden they're going to say yes. So, I think for them, if I'm asking all the time and then all of a sudden they're starting to have some symptoms, they feel comfortable with asking. So that's kind of my own personal way of just reducing stigma.
Yeah.
And I might just add one thing. I think actually, Heather, you kind of spoke to this, but the more that people that have had these experiences or have family members, friends, loved ones that have had these experiences and they talk about them, what Alexis has done today is really powerful and it's really brave. And I hope we can get to the place someday where we don't even think of that as brave anymore, right? That it is totally normal to be talking about these things because they're common, they happen frequently, they're really hard. And so I think the more that people can share their stories and the more that other people can look at that person and say, oh gosh, I'm just like them, right? Like this is a normal thing, the better off we'll be.
Yeah.
I just want to say one more thing. 2020 Mom, the organization I'm with, also has a group and a site. It's called the Blue Dot Project, Blue Dot Project. And they are so wonderful. Their mission is to reduce the stigma and give mothers and families a place to a community to talk about their stories and to receive support and just be with the community, because that is so important when you're going through something so hard.
Yeah, that sounds like a great resource. Thank you, Heather. Sort of building off that, it sounds like a lot of the things we can do to reduce stigma is just sort of opening up this dialogue. Are there other ways that folks can really support a loved one that might be experiencing PPD?
So I think there's a lot of ways. There's some really good resources to start with if you are trying to access help or figure out how to help a person. So Postpartum Support International, Moms 2020 is I agree, is a great resource. And then it can just give you a sense of where could I get help in my area. But I would say that, you know, in the immediate, how do you help a woman right then and there is giving her the time to replete herself. So having a baby is emotionally, psychologically, physically, financially depleting, and people need to replete themselves so that they can have the energy to take care of themselves and their babies. So as much as you can free up that woman's ability to rest and replete, the better. So if it's just getting her consecutive hours of sleep so that she can then function better. So just thinking about how can I help support this person to rest and repair and yeah, have some self-care.
That's great. Thank you. Heather or Dr. James, you have any other advice?
Well, I would say that what we find is that there's a lot of differences when it comes to different cultures in terms of how available or acceptable family involvement is. In some cultures, the family is extraordinarily involved and is an integral part of screening, treatment, and management. And in others, you know, the culture is such that they can't discuss it with their family at all. And so I think it's really important for providers to know what their patient population is like and to recognize those differences and utilize that in their screening and treatment. You know, in my community, I'm in Miami, Florida. We have a very large Hispanic population, and Hispanics react differently than, and obviously that's a stereotype, but in general, there's data to suggest that Hispanics will act differently than, let's say, African Americans. And we have a large Native Indian population, and they have a completely different type of affect and type of way of communicating. So I think that that's an important thing to recognize.
From a non-clinical point of view, I have a little acronym that we like to use just in our with maternal mental health in Utah. The acronym is SUNSHINE, and it's really great to remember the basic things that you can help your the mother struggling to get so she can manage everything she's going through and hopefully try to thrive. So the S is for sleep. The U is for understand, which means talk to a therapist, help them get to someone who can understand what they're going through and hopefully help give them adequate treatment. Nutrition is a big thing. We need to make sure that a mother struggling has the adequate nutrition she needs, especially if she's breastfeeding. She needs to get in those extra calories and get in healthy foods that will help her recover and feel good. Support is another one, community, family, neighbors, anything like that. Humor is a big thing. When we're all feeling down, one of the best things we can do is turn on Netflix and watch an episode of our favorite show. So we remind our mothers in our community to watch something that makes them laugh when they're feeling down. Information is a big thing for this. That's screening, making sure that we're constantly screening mothers who are struggling, making sure that they have the support, and a definitive diagnosis is often really helpful. Nurture is self-care. And the E in SUNSHINE is exercise, and getting those endorphins to help improve that natural mood boost and feeling better.
That's fantastic.
Yeah, I love that. So we've heard the word screening tossed around a few times, and we had a question come in where we would love to hear the panelists speak a little bit more about the screening process and some of the screening tools that are used. We're going to talk a bit more about the standard of care for PPD in our second webinar on the 17th, but just briefly discussing some of the screening tools that are used would be great. Yeah, Dr. James.
So I'll tackle that, since I think the screening should, often start in the obstetric period, and from a psychiatry standpoint, we're usually referring patients there. Although if patients have a pre-existing relationship with a therapist or psychiatrist, then obviously they may be screened. Probably the standard of care, or the most commonly used, I would say, screening mechanism is the EPDS, which is the Edinburgh Perinatal Depression Screener, which it's non-judgmental. It is 10 questions. It's available in like over 50 languages, and it's pretty standardized scoring. That's what we use in our hospital, and I use it in the postpartum period. It's free and available on the web very easily. You can put it on a clipboard or an app or any of a number of ways. It is also not the only screener. Other very popular or commonly used screeners are one called the PHQ-9, and I'm a huge advocate of something called the PHQ-2, which is just a 2-question screener that really, if any clinician says they don't have time to screen or they don't have the ability to screen, you literally can ask 2 questions. And even if you don't want to use the scoring that goes with the PHQ-2, which has a score of 0 to 6, you could just ask those 2 questions. And if the answer is yes to one of them, you just know that they probably would benefit from additional screening. So the questions are, over the last 2 weeks, how often have you been bothered by little interest or pleasure in doing things? And over the last 2 weeks, how often have you been bothered by feeling down, depressed, or hopeless? And really, if they just say yes to either of those 2, then I think they merit maybe a little more in-depth screening, a conversation, or an EPDS. I mean, I think that any screener is not really comprehensive enough, because I could do an EPDS on a patient and it could be a high score, but she could have just lost her dog 2 days ago and it would be positive. So a screener is just a tool, and the conversation is what's going to really help you to determine what this patient is experiencing. But there's really no excuse to say I don't have time to screen, when you can ask 2 very simple questions and kind of segregate your population out into who needs additional evaluation and who doesn't.
That's great. Dr. Gale, Heather, anything to add on this topic?
No, I think as long as you're using just a validated screener, the Edinburgh Postnatal Depression Scale is great. PHQ-9 is great. Whatever you can fit into your practice is wonderful.
Great. I'd love to talk a little bit about everyone's thoughts on how COVID-19 and sort of these increased feelings of loneliness and isolation that have, really become quite common. How has that sort of impacted PPD rates and severity?
I can start with that, and then you guys feel free to jump in. So, there's been a couple of papers published showing close to a doubling in rates of postpartum depression and anxiety. So these numbers are definitely increasing. I can see in my own practice, our average monthly volume has increased by 120% since the start of COVID. So we are seeing many more women. Part of that is also because we can see them virtually in their homes, which creates much better access to care. So I think it's both a demand and also better access. I think if you go back and think about the slide that we went through about risk factors for postpartum depression, COVID is exacerbating every single one of them. So women are just more prone to these risk factors and then more prone to postpartum depression. So it is certainly on the rise. It feels like an impossible situation sometimes, where you're seeing a woman, what's needed. She needs increased support so she can get some sleep and some help, but there literally is nobody that she would feel safe with, or would actually legitimately be able to help during this time. And so it is such a challenge right now to treat women appropriately and thinking about the whole picture. And so we've tried to be as creative as possible, but it is a major challenge, and women are really struggling. And I'd say families are really struggling during this time.
Yeah, sorry, go ahead, Dr. James.
Yeah, I'm sorry. I'll speak just briefly. No question that COVID has increased all the risk factors, as Dr. Gill has said, and I think the most impactful one has been feelings of isolation. Not being able to socialize, go out, be with friends, utilize resources. One of the attendees asked within the chat box if COVID has decreased the number of times I see patients in the office, and if that's impacting PPD. And the answer in my practice is no. I mean, we're still seeing patients just as often as we were. And so it hasn't really significantly affected it. But certainly we're seeing more concerns about PPD and more prevalence of it, a little bit of an uptick. And so it's something that we're certainly cognizant of.
Just piggybacking off of Dr. James, I work closely with the Utah Health Department, and we're able to track how many moms go to their 6-week appointment, and based on responses to some online surveys we send them. And it's alarming how many mothers last year didn't go to their 6-week checkup, or didn't go to perinatal checkups because they were so afraid of leaving their home that they just let these appointments slide by and hope that everything's okay, and assume that it's worse to get COVID than it is to be screened and to get a checkup with your physician, which is understandable. And another thing that we've had problems with on this issue is that not every medical practice has been prepared to immediately jump online. So to meet that need of being fearful of leaving your home, we haven't been able to provide telehealth. So in the state of Utah, I can say that we've seen a lot of moms fall through the cracks because they don't want to leave home.
Yeah, it's a hard decision. I think a lot of moms and people in general are faced with nowadays. We're definitely going to expand on this COVID topic more in our second webinar. But with our last few minutes, I wanted to see if our panelists have any helpful resources that they wanted to plug. We are going to share some resources on the next 2 slides, but I just wanted to give our panelists a chance to speak about any that they would like to promote in particular.
Heather, I feel like you should go on this one. You guys have so many great resources.
Sure, yeah, I'd like to. 2020 Mom is so great. They are perfect for providers looking for help. Someone asked about where to get screenings, and 2020mom.org has lots of resources like screening tools. There's a whole different selection that you can go through from Edinburgh to 2020 Mom's own screening tools, and Postpartum Support International is another great place. And for providers, again, Blue Dot Project is so great for helping plug women into a community of survivors. So those are the 2. And Postpartum Support International, who 2020 Mom works really closely with, is another great place for the maternal mental health certificate training for providers.
Great, thank you so much, Heather. And thank you so much to Dr. James and Dr. Gill and Heather, of course, for your insightful discussion today. I wish we would have more time, but yeah, please join webinar 2 and we'll discuss PPD and clinical trials in more detail.
Well, thanks for having us. I really appreciate it.
Yep.
Thank you so much.
We could just go to the next slide. We can show some links. If you feel as though you need immediate help or you may harm yourself or your baby, please call 911 or local emergency number. You can also call the National Suicide Prevention Lifeline at 1-800-273-8255. It is available 24 hours a day. If we go to the next slide, we'll see some additional resources that have been provided by Sage Therapeutics. The first link here is to the Skylark PPD clinical trial that Sage is sponsoring, which they're currently enrolling. The next is linked to 2020mom.org, which Heather spoke about, has some really great valuable resources. And lastly, a link to the patient advocacy page on Sage's website. Of course, yeah.
Can I say one more thing?
Yeah, of course.
Postpartum Support International has a warm line as well. So if you, the suicide hotline, of course, is always a great place to go. But for postpartum and perinatal, mood and anxiety disorders, this Postpartum Support International Warm Line is a great place to go to get mother-specific resources as well.
Awesome. Thank you so much, Heather. Just want to mention that, of course, these resources are not intended to replace medical advice, and you should always talk to your healthcare provider and treatment team about any medical decisions or concerns that you may have. And lastly, as we near 4 p.m., the end of our webinar one, I just want to give a huge thank you to Sage Therapeutics for sponsoring this webinar series. And again, a huge thank you to Alexis, Heather, Dr. James, and Dr. Gill for being with us today. Next in the webinar series, we'll discuss in more detail clinical trials in postpartum depression. And as a reminder, this will be on February 17th at 4 p.m. We hope that you'll join us then, and thank you so much for joining us today.